Welcome, welcome to Hampstead Garden Suburb U3A. I am well and truly delighted to invite a speaker back to our platform, so it's lovely to see you again, Gordon. The talk today is how medical advances since the 1890s benefited one patient. In this talk, Gordon Rustin, who's here, brings 130 years of medical progress to life through the remarkable story of one female cancer patient who benefited from 21 lines of therapy. Tracing her journey back through time, he reveals how the diagnostic tools and treatments she received were discovered, blending medical history with the excitement of modern breakthroughs. Can I please welcome Gordon Rustin to our platform?
Lovely to see so many people who've come out of the sun to listen to me today. I'm using one patient as an example of how medical advances have benefited her. And I've said from the 1890s, and the reason I say the 1890s, because before the 1890s, the only treatment available for cancer was surgery. And if you think about it, before the 1890s, even surgery was pretty basic because there were two major problems with surgery. First, sepsis. Second, pain control and anesthesia. Probably many of you are not aware that sepsis in infection related to wounds has actually been known since 460 BC, when Hippocrates suggested washing wounds with vinegar and wine. It's amazing that, we still use alcohol wipes today, but that goes back to 460 BC. But really, there were no advances in sepsis control until really about 1840, 1850, when there was an Austrian gynecologist who was basically the first person in the world who suggested that you perhaps should wash your hands before you do an operation. And by using carbonated lime, he managed to reduce the puerperal sepsis, that's deaths basically, following childbirth dramatically in Vienna. But that was only the 1840s. Ether was actually discovered about the same time, but it wasn't really used very much. And then we have to wait till Joseph Lister in the 1860s before carbolic soap and people generally started washing themselves, and we got a bit of sepsis control, but that was just surgery. And it was 1895 that X-rays were discovered, and it was only 1 year after they were discovered that people actually started using X-rays to treat cancer. And it was a woman with breast cancer was the first person in the world ever to get radiotherapy. And then it was just 2 or 3 years later that the Curies discovered radium, and then radium treatment came in. But that takes us a little bit further. But we've got 1900s. What happens after that? We really had to wait to the 1950s till the next advance. But let's come on to Millie. Millie I first met in 1999, and she went to her GP because her sister had just died at the age of 46 from ovarian cancer, and she had a first cousin who also had ovarian cancer and had died. And so she, not surprising, was very worried. She went to a GP and said, "Could you remove my ovaries? I'm worried about that." So she the GP very sensibly thought that's a reasonable thing to do, referred her on, and not surprisingly, before she had her ovaries removed, they scanned her. Now, we talk about scanning as if it's such a simple procedure, but I mentioned that X-rays were discovered in 1895. They were good for bones. You could see something, lumps in the lungs, but anything in the abdominal cavity, X-rays were useless for. And does anybody in the audience know when the first ever scan was performed, the date of the first ever non-X-ray scan? It was actually It was actually 1956. And it's amazing how that came about. That was an ultrasound scan. You can see a baby. And it was performed in Glasgow, and the reason that it happened was that the steel industry was very worried about bubbles in steel that could make it fracture. And so they had asked a scientist by the name of Tom Brown if he would try and develop methods, and he realized you could perhaps use ultrasound. I'm not sure it was called ultrasound then, but bouncing sound waves through the metal. And he happened to be friendly with a gynecologist, and that's why they decided to do an ultrasound scan. So that's only 1956. But what about, ultrasounds are reasonably good, but they're not that good. What you really want is something a little bit better. And we're very grateful that Sir Godfrey Hounsfield, he was the most brilliant guy. He worked in radar in the 1940s and joined EMI in 1949. And he produced the first transistor computer in this country, and was obviously a completely brilliant person and was doing amazing things at EMI. And again, it was lucky, because he was doing all these amazing things just at the time that EMI had a lot of spare cash. Can anybody tell me why they had all this spare cash? The Beatles, yes, they own the rights to the Beatles. They had this brilliant guy, and they said, why don't you do a bit of brainstorming and work out what you would like to do? And he said, well, I would like to try and see if you could find the contents of a box by external means. Could you interrogate what's inside a box? And so he started thinking of ways to do it, and he thought, well, if you shine X-rays from all around it, could you get a 3D image of it? And it was fortuitous that, again, he happened to be friendly with a neurosurgeon who was working at the Atkinson Morley. And this neurosurgeon said, well, I'd love to know what's inside this box. And so, resulting from that, was the very first ever CT scan performed, which was at the Atkinson Morley Hospital on the 1st of October 1971. And you can see that's the CT scan of somebody's head, and you can see that black shadow, and that is, and that is, there, wait a minute, let's just, I'm sorry, it's, I can look at this one, yeah. Yeah, right, so, sorry. That's where I am. You can see the black shadow, which is the tumour in that person's brain. But would you believe it? They did the scan. It required over 3 days of computing power to actually produce that picture. Can you imagine that? I mean, the computer that we all have in our pockets at the moment, could do that in milliseconds, but it took 3 days then. So this is a CT scan of Millie. And what you can see are some arrows. And those arrows point to little nodules, which was fairly terrifying, because here was a woman of 46 who went to a GP completely well, just saying, could you please remove my ovaries? They do a scan and they found there's cancer in nodules throughout her abdominal cavity. So this really is a silent cancer. A cancer, if you look at the head of that needle, that is about 1 centimetre, which contains about 100 million cancer cells. And if you're trying to find far fewer than that number of cancer cells, it really is a bit like a needle in a haystack. How are you going to do it? And many of us around the world in the 50s, 60s, 70s were trying to develop tests in blood or urine which might be able to pick up a cancer earlier. And the way many of us were doing it was we had cell lines of ovarian cancer, and you would inject these, you extract various things from these cell lines, inject them into mice to try and produce antibodies. Well, Bob Bast was a colleague of mine in Boston, and he had 125 cell lines to play with. And he played with 124 and got nowhere. He really hadn't found any decent antibodies. And because every time he got a cell line, he'd put chemicals and try to extract chemicals and injected those into the mouse. And he was getting a bit fed up, so he said, right, this time I'm going to just get the whole cell line, put it in a homogenizer tube, homogenize it, and inject the stuff into a mouse. And hey presto, he came up with his antibody. And the reason why that worked, we now know, is because CA125 antigen is a very big molecule which goes through the membrane, and if you try and sort of put chemicals and extract it, you damage the 3D structure and you don't get a decent antibody to it. But he managed to get this antibody, and it was the first decent test for ovarian cancer. So you've got a test that you can perhaps monitor ovarian cancer. Can you screen for it? And so we all started wondering whether that was possible. And when you're thinking of screening for cancer, there are certain things you have to think about. You think, can we do it? Well, we've now got a blood test. Do you think that is possible? The next thing is, should we do it? Well, obviously there's a huge need because it's a silent cancer. Can we pick it up earlier? But then there are two really important things you've got to work out. The false negatives. We know, we had appreciated by then that about 85–90% of patients with ovarian cancer had this elevated CA125. But, and this is a very big but, only about half of the patients with stage 1, that's cancer just within the ovary, had an elevated level. So if you think about it, the sensitivity, the proportion of patients who are likely to benefit are going to be considerably less than half of all the ovarian cancer patients. That's the first problem. Then you have false positives. This blood test goes up with various conditions such as endometriosis, but it also goes up when women have periods. So basically, that rules out all premenopausal women. But despite all that, there was a colleague of mine at UCH, Hal Jacobs, who was very keen to try a test, and he managed to persuade the Medical Research Council to put up about £8 million. And some of you in the audience, I know at least one who was involved in this trial, they set up a trial of 200,000 women. And I'm labouring this because screening of cancer is a really high-profile thing at the moment, particularly prostate cancer. And you need to know some of the problems associated with screening. So in ovarian cancer screening, they needed to do a trial of 200,000 women. A third of them had no screening. A third of them, they had this blood test done every year to see if there was a slight raise, and the other third had ultrasound. And you can see this trial showed that although there was a considerable earlier pickup of ovarian cancer in those who had the blood test. Well, I'll talk. Can you hear me? No. I mean, can you hear me if I shout loud, talk loud? Okay. Oh, you'd like me to wear it? Okay, can you hear me now? Right, okay. So the women who were having the regular blood test, ovarian cancer was diagnosed at a very earlier stage in far more women in that group than in the control group. But, and this is the really important thing, as you can see from this slide, there was absolutely no difference in survival between the screen group and the non-screen group, which means that you're actually disadvantaging women because you're actually telling them they've got cancer several years earlier than they might otherwise have got cancer, but they're dying at the same day. So they're actually living with the knowledge of cancer and going through all the treatment for nothing. So you can see screening can have big downsides. Okay, that's working, right. So unfortunately we still don't have adequate screening for ovarian cancer, but I think things will improve before long. So Millie had her operation in March 2000, and not surprisingly, she was found to have what we call stage 3 ovarian cancer. It spread throughout the abdominal cavity, and it was all removed. And so it's not surprising that, right. We knew that she had an elevated CA125, and we also knew that she required chemotherapy. Right, so you remember I started my talk saying what we had available for cancer up to the early 1900s. And there was a big gap after that. So I'm now going to take you a little bit through that gap as to how we got to the chemotherapy that Millie actually received. And this, again, starts in the, oh gosh, I only press one. Why does it? There, right. She required chemotherapy, and, right. So we're going back now to the 1880s, and there was a brilliant scientist by the name of Paul Ehrlich. He was a German, well, he was actually originally Polish, then spent all his life and work in Germany, Jewish physician, who was again very lucky because his first cousin, Eric Weigart, was the first person in the world to find that you could stain microscope slides to detect parasites and other things. If you think about it, if you want to look down a microscope at a tissue, it all looks a sort of a mess unless you can stain it and actually pick up different things. And this is a slide using the dye trypan red, which shows the parasite trypanosome that causes sleeping sickness. And you can read very clearly that it stains up. And Paul Ehrlich had this idea that if you can find a chemical that goes just to one particular tissue, i.e. staining it, could you find chemicals that actually would kill that parasite or cancer? And so he devised the whole concept of the magic bullet. And so he was involved in this, but he really made his name looking at a whole, I mean, he was the first person to start doing systematic studies of chemicals, just slightly modifying the structure to see if they were more effective at, he was looking at killing bugs, but one of the bugs that he was particularly interested in was a very similar parasite to the trypanosome that caused sleeping sickness. It was the parasite that causes syphilis. And syphilis at that time was a completely incurable condition. So you found other chemicals based on arsenic that, in fact, it was the 606th synthesis that he did of an arsenical compound that came up with the first treatment that could cure syphilis, salvarsan. And there was a film made about Paul Ehrlich and the story of the magic bullet, and it was both a good news and a sad story, because the fact that he had found a chemical that could treat syphilis meant that drug companies suddenly got excited, and Hearst bought salvarsan. And would you believe it, in 1913, it was the most financially successful drug in the whole world. So it was a megastar of the pharmaceutical industry. And I couldn't believe it when I read it, but there were people in Germany, partly through anti-Semitism, but partly for other things, who felt that you shouldn't be interfering with the natural history of disease. And they accused Ehrlich of immoral practices. Obviously, he was making quite a lot of money, so they were jealous of him. And they were libeling him. And there was this particular guy, Wasserman, who was a publisher in Berlin, that Ehrlich actually took to court. And I couldn't believe it in those days in Germany. If you failed a libel action, it was criminal. And this fellow Wasserman went to prison. But Ehrlich tragically died soon afterwards. But that was the development of the person who really founded the whole concept of chemotherapy. Then we move on. What happened next to try and develop chemotherapy? And tragically, we go to the First World War. And this is a picture of soldiers who'd been gassed with mustard gas. And it did terrible things to people. And there were pharmacologists, Goodman and Gilman, in the United States, who were asked by their government to investigate ways of trying to counteract the effects of mustard gas. And they both were looking at that and also trying to find out more the impact of mustard gas. But through their work, they came up with a particular derivative of it, which they thought might actually be useful for treating patients. And they, in 1941, the first patient in the world was treated with chemotherapy for lymphoma at Yale, and they used a derivative of mustard gas. But that was one patient during the war, and things went pretty quiet. But what really propelled things was another terrible event. I mean, it's amazing how advances often come through rather bizarre pathways. This is a picture from the 2nd of December 1943, when the SS John Harvey was bombed in Bari Harbour, and in southern Italy, whilst during the invasion of Europe by the Allies. And would you believe it, this was an American warship, well, it was an American cargo ship that had 2,000 mustard gas bombs on board. It was US, not the Germans, the US. And this was completely, nobody was allowed to know about this, but there was a colonel who came over from Alexandria to try and investigate all this, because there were a huge number of casualties. And what they discovered was that a lot of the soldiers and sailors who were, particularly those who had to jump into the sea, because of course there was flames and they were trying to escape the ships sinking, these soldiers and sailors were dying from infection 2 or 3 weeks later, and they discovered that all their white cells had disappeared. And what had happened was that the mustard gas had dissolved in the seawater, had been absorbed through the skin, and had damaged their blood vessels. And luckily, all this was completely suppressed. Churchill was involved in the suppression of anything to do with this. It was lucky that there was a General Cornelia Rhodes who was senior enough to have information about this, and he took it back to NIH at Bethesda, and they thought, gosh, if there's a chemical that can destroy white cells, could it destroy leukemia cells? And so it was in 1949, they actually licensed a drug, mustine, which was the first cancer chemotherapy drug. So that's where we get up to almost 1950. So we started chemotherapy, but those drugs are no good for Millie. Millie had to wait for another strange event. That's a platinum wedding ring. What's platinum got to do with cancer? Well, platinum, if you dissolve it in the right chemicals, well, it's soluble. You can dissolve it. And platinum is used in electrodes, and there were some scientists who were trying to see the impact of an electric current on the growth of bacteria. And they were, like many scientists, they were trying to do too much. So they had all these dishes of bacteria in growing and putting electric current through them, seeing what it did to the bacteria. And they had a group of dishes that they hadn't had time to deal with, so they just left them on the side of the bench overnight. And when they came in the next day, they discovered that all the bacteria were dead, and they hadn't put any electric current through them. So luckily they investigated and realized that the platinum in the electrodes had dissolved into the liquid and had killed the bacteria. So it was thanks to that two drugs, cisplatin and then carboplatin, were developed by Johnson Matthey in this country and became really the two drugs that made the biggest difference to two cancers, testicular cancer and ovarian cancer. And there was another drug that, based on the of the tax from the Pacific yew tree, Taxus brevifolia, and scientists extracted chemicals from that tree and also from the European yew and produced Taxol. So coming back to Millie, she received, so I'm going to be showing several slides like this. If you look, there is an arrow showing when she got the chemotherapy, that big red arrow. The scale on the left is the level of CA125. So this is the chemical that I mentioned earlier that was discovered by Bob Bast, that you can see, is elevated in a large proportion of women with advanced ovarian cancer, and by doing measurements you can tell whether the cancer's shrinking or whether the cancer's growing. So Millie had 6 cycles of this platinum drug with a taxane, docetaxel, in a trial. Many of our patients go into clinical trials. You can see her levels dropped, and then she went into a clinical trial called the OV05 trial. And now, these are graphs of 2 patients, showing what happens when you monitor CA125 during somebody's treatment. You can see on the left, the levels fall. Those little black lines are when they get the chemotherapy. And you can see it falls down to that little dotted line, which is the normal level. And then, unfortunately, most women with ovarian cancer relapse, and you can see the levels going up. Now, the yellow level is, you've noted the level going up, but the woman is completely well. So when I first got hold of this CA125, I was measuring it regularly in patients, and I could see the levels going up, and I wasn't absolutely sure, did that really mean that the cancer was coming back? Because we'd only just started using this. And you can see that when it gets up to the red point, that's when patients develop symptoms. And so over a number of years, I was aware that I had many, many patients, some of whom would go 2, 3, 4 years between their CA125 level rising and them actually developing symptoms of recurrent cancer. And they were completely well during that time. I was also aware that my colleagues in America, they were doing CA125 tests on their patients, or their patients were demanding these CA125 tests, and they were getting them done every few weeks. And the level would go up, of course they would tell the patient, and the patient would demand treatment. And so my patients, on the whole, were like the top line, so I would wait until the patients got symptoms and then treat. The Americans would be treating every time the CA125 started going up. So during a patient's journey, say my patients might be on chemotherapy a half or a third of their cancer per journey. The American patients would be on chemotherapy 80–90% of their cancer journey. And I suspected that the American patients possibly might live a few months longer, but would they actually, what was their quality of life? So if you've got this quandary, you do a clinical trial. And so with Maria van der Berg from Rotterdam and with help from the MRC and the EURTC, I set up a big trial where women who had gone into remission from ovarian cancer, like Millie had, a CA125 had gone down to normal, they had their CA125 measured every 3 months, and the results were only sent to the Medical Research Councils, and the doctors or the patients didn't know the results. And if the levels started rising, patients were randomized. Half we treated straight away, half we just kept on watching. And after we'd entered 1,442 women, we were able to see enough events to analyze it, and the results of this trial were selected as the most important presentation in the largest cancer meeting in the world in 2009. It was probably selected partly because Obama had just become president, and the whole concept of Medicare and healthcare was becoming more important, and so a big trial like this was important. So I had to give this presentation in front of 15,000 people, and I have to say I've never experienced anything like the gasp of surprise when I showed the result. Which showed that there was absolutely no difference in survival between those who had been treated early or who delayed their treatment. And it was very strange after I presented this trial. I thought people would be so thrilled that we could, that patients would benefit. But I became a hate figure in the United States. Everybody was trying to disprove what I had shown, because of course, treatment means money. And I was costing the American oncologists a lot of money because the patients could say, well, actually, I don't need this treatment. And it made me realize that Max Planck was absolutely correct when he said a scientific truth does not triumph by convincing its opponents and making them see the light, but rather because its opponents eventually die and a new generation grows up that is familiar with it. There's another term called cognitive dissonance, which is obviously used these days to explain that. But still, coming back to Millie, she was on this trial. She was randomized to immediate treatment and decided to have another trial treatment, a tablet treatment, and you can see the levels went down a little bit. Then she had more carboplatin, the levels went down a bit, but then it relapsed. She then got cisplatin etoposide, which is a really horrible treatment, but she had a response. And then she relapsed again, and she said, well, have you got any more clinical trials I can go into? Well, this just happened. Sorry. Right, yeah. This happened just at a time when there were new developments in cancer treatment attacking tumor blood vessels. And there were two approaches. If you think about it, a cancer is growing. Anything growing needs a blood supply to survive. So growing cancer needs growing blood supply. If you shut down that blood supply to the cancer, it's like the Achilles heel, you'll kill the cancer. And there were two approaches to this. Judah Foltman in the United States was pushing the idea of preventing the new blood vessels growing. And Juliana Denenkamp in the United Kingdom was pushing the idea of could you actually destroy the tumor blood vessels. And the reason she said, could you destroy the tumor blood vessels, is because if you look on this graph, this is a cast of normal blood vessels on the left and tumor blood vessels on the right. And you can see they are very different. They're very disorganized, the tumor blood vessels. And she thought, could you actually target them? And I'll never forget, in about 1987 or 8, she called me into her office and said, Gordon, I want to discuss an experiment we've done, which is very exciting, but is of no value to me, but it could be of value to you. And I said, really? Now, she was the director of the Gray Laboratory, which is the largest radiobiology lab in the world. And I was at Mount Vernon working with her, and the whole concept of radiotherapy, how does radiotherapy kill cancer cells? It reacts with oxygen to produce toxic radicals that kill the cancer cells. If you have a big cancer, the big cancer has very little oxygen in it. And that's why radiotherapy doesn't kill the cancer cells in the middle. And she was developing ways to try and increase the oxygen to the center of the cancer. And she'd come across, but she'd been sent this drug by our colleagues in Auckland, New Zealand to test. And she showed me the results, and she'd had these tumors in mice, gave this drug, and within 45 minutes, you could see the whole cancer nodule just disintegrating in front of you, because it completely shut down the blood supply. So thanks to that, I sort of quickly got in touch with CRUK, and we were very grateful that there were scientists who were suddenly getting interested in this. And somebody who I worked with at the Gray Laboratory was friendly with this fellow, Bob Pettit, at the University of Arizona. Now, Bob Pettit was a chemist who used to go around the world trying to work out why exotic plants and animals were not eaten by predators, with the concept that things that are not eaten probably have toxins inside them that stop people eating them. And he, on his travels, he was in South Africa, and he got chatting to some Zulus and discovered that the Zulus, for hundreds of years, had been painting the tips of their arrows with an extract from the African bush willow. And he so he took lots of the African bush willow home with him and extracted chemicals called combretostatins. I mean, basically, because the African bush willow is called Combretum caffrum, so not surprisingly, he used the word combretostatin for the chemicals. And I was, so we thought it's time we started testing these in humans. And again, I was very lucky because at Mount Vernon we had a fantastic scanning centre that was privately funded, and they were very interested, or they just developed, using a special contrast that you could inject whilst you were having an MRI scan, to actually measure blood flow real time in patients. So I was the first person, the first person in the world I gave this drug in, I think, 1999. That's me actually at Babylostorum in South Africa with an African bush willow plant, and that's the big tree. And this is right. So I mentioned that we're doing these dynamic MRI scans. So 4 days before this patient received this antivascular drug, the red areas are where you have lots of blood flow. The cancer was, well, you'll see in the next picture, 4 hours after we gave the drug. That's where the cancer is, where that line, the arrow. 4 hours later, you can see where the cancer is has gone blue, which means the blood supply has gone. So, I mean, to be able to demonstrate that, and if you actually look at what happened to Millie, you can see that she had a response to the cisplatin and orotoxide that lasted almost a year. When we gave her this Taxol and this antivascular drug, it lasted for 20 months. So this was a considerable advantage. And we continued. I mean, she actually had 22 lines of treatment, but we're just at the 17th here, and she responded to platinum on 10 occasions. So she kept on, how is it that this lady has a cancer that she responds so many times? I mean, you don't really normally hear of that. And one of the possible explanations is the BRCA gene. Now, many of you might have heard of the BRCA gene, but I'm a great believer in every cloud has a silver lining. Now, BRCA was discovered in BRCA1 in 1994, BRCA2 in 1995. They are DNA repair genes. And if you are unfortunate to have a BRCA mutation, you're more likely to get cancer. But if you do get cancer, that cancer is far more sensitive to chemotherapy than somebody without a BRCA mutation. And we now know that about half of all women with ovarian cancer have a defect in one of the DNA repair genes. Okay, BRCA and BRCA2 account for about 15–20% of those, but there are others as well. Now, we know that because these repair genes are so important, people have developed chemicals to interact with them. Now, this looks complicated, but actually it's a very exciting slide. On the left-hand side, you can see a normal cell. There are two ways to repair DNA damage. We've all got DNA. I mean, these are very important pathways because all the time we're being bombarded by UV radiation, other radiation. We're eating the most stupid foods which have all these toxins in them. And there's so many carcinogens around, you've got to repair the DNA damage. And so the body has produced two ways of repairing DNA damage. One of them is by this BRCA gene, and the other is by an enzyme called PARP. And so normally DNA is well repaired. If you have a BRCA gene, you don't repair DNA so well. And that's probably why those cancer cells that have a BRCA mutation are so sensitive to chemotherapy. But you've still got the PARP. They've now developed ways of blocking the PARP enzyme, and if you give a PARP inhibitor to somebody who has got a normal BRCA gene, that's the second to the right, the DNA can still be repaired. But if you've got somebody with a BRCA mutation or another DNA repair mutation that's damaged, and you give them a PARP inhibitor, the cells die. And so this is another great advance. And this is a clinical trial where women who went into remission with ovarian cancer then were started on a PARP inhibitor, and it dramatically has improved survival. So that's really a very exciting advance. Now, Millie did not have a BRCA mutation, but she must have had another defect, because, I mean, unfortunately, when she died, we still didn't have all the molecular biology tests to try and detect the other enzyme that involved. I'm sure that she would have got many more years of life if we'd been able to give her a PARP inhibitor. Whole gene sequencing would have shown a mutation that was likely to benefit her treatment. And whole gene sequencing is now being used in so many different types of cancer to get specific targets. We're getting better understanding the whole time of the triggers for uncontrolled cell division, which I'm sure will provide many new therapies. I talked about what happened, big change in 2000 was the introduction of immunotherapy, and that's now having a big impact. And we're developing far more new sensitive methods to detect cancer early, so screening will improve. So I hope I've shown that I'm convinced there will be big improvements in the management of many cancers over the next few years. And I hope that my presentation of Millie's cancer journey has helped you to appreciate some of the medical advances since the 1890s that enabled her to survive 12 years. Thank you very much. But the question was, are there any new screening methods involved in detecting, well, there are new screening methods looking at DNA, naked DNA, and other things in the blood. I mean, there's a new buzzword called liquid biopsies, where normally you'd have to actually take a lump of something, but now often you can take a blood sample, and by looking at the molecular profile and DNA, you can get an earlier diagnosis. But, I mean, that's moving quite rapidly. But, again, you have to do huge trials to show their benefit.
Another question?
Hello.
Yeah.
Over the years, has the personality of cancers changed at all?
Well, the only thing that's changed is we're all living longer. And so we've all got a bigger chance of getting cancer. And don't forget, a quarter of all men over the age of 70 have prostate cancer. So, but don't forget, most men were dead by 70, 50 years ago. So we didn't know that. So when you're talking about the personality of cancer, it's just because we're all living so long that we're pardon? No. I don't think there was much big change, no.
How was it determined that some chemical from this African willow was suitable for treating cancer?
Right. Now, that's a good question. I mean, and this is what's amazed me, because this fellow, Bob Pettit, took the African bush willow back to his lab, and he extracted a whole host of different chemicals. And it was at a meeting when he was with a guy called Di Chaplin, who I worked with, he was showing them all the chemicals that he had discovered. And this guy Di said, gosh, I mean, he looked at the chemical structure and he said, I bet that's going to bind tubulin. And it did bind tubulin. And it's the tubulin, and the way that drug works on the blood vessels is that it actually stops them. When the blood vessels grow, you obviously have a coat round, and this tubulin, when you block it, it stops the blood vessels enlarging, and so all blood gets stuck inside. Yep.
Thank you. You referred to Dr. Semmelweis in the 1840s. What you didn't say was he was not liked by his contemporaries. They absolutely hated him.
Oh, absolutely.
And he eventually died from from sepsis because nobody listened to what he was doing.
Oh, I absolutely, no, it is, you're quite right, it was horrifying. But I mean, it comes back to what Max Planck said. Yes. I mean, new advance, you have to let people die off. I mean, but carbonated lime was pretty horrible. And it was actually, the staff didn't like all this, I mean, they're all the same, skin went red raw and everything, I think. So, I mean, but still, it had a huge impact on puerperal sepsis. Alan, do you want, oh, sorry, you first.
I'm confused. If Millie had an oophorectomy, what were her symptoms from afterwards?
Oh, right. Good question. Basically, you could see all those nodules that on the scan. Obviously, they weren't all removed. I mean, you thought you removed them, you couldn't, but they were microscopic, and so they were growing back.
But why weren't the ovaries removed completely?
Oh, the ovaries weren't removed completely, but the cancer that killed her was cancer that had spread from the ovaries. Okay. In fact, actually, even that is wrong. We now know that cancer of the ovary is a very, very rare disease. What cancer of the ovary we now realize actually is cancer of the fallopian tube. And that explains why it's such a silent cancer, because obviously the fallopian tube, things float off the fallopian tube to get to the ovary. And that's why it's so advanced by the time we pick it up.
One final question.
Thank you. Could you talk about the order of treatment? I know somebody who had pancreatic cancer, 6 months of chemotherapy first, which did absolutely nothing, and then just 5 doses of intensive radiotherapy stereotactically, and that shrank the tumor from 3 centimeters to less than 1. And yet there's a protocol which says you must do chemotherapy first. When will people learn which is the more effective?
No, that's another very good question. I mean, but it comes back to why was Millie's cancer so sensitive? I mean, everybody's cancer is different. and there've been many attempts to try and grow cancer cells from patients outside the patient to see what is the best treatment for them. I mean, individualized treatment. Because obviously, if somebody's got a chemo-resistant cancer, the last thing you want to do is really make them bloody unwell with something that is not working. And so that is a really big issue. And it's, and that's why, I mean, one of the reasons I got involved in ovarian cancer, and particularly once CA125 had become available, is because you could monitor the disease and see very early whether the treatment was working or not. Because your moan wouldn't have been quite so bad as if you'd only got one cycle, showed that one cycle didn't work, and you change. But to get 6 cycles and it not work, that is, I mean, you don't want to do that. But unfortunately, if you can't monitor it closely enough to see what's going on, you can grossly overtreat people.
We are really very, very privileged to have you on our platform. Thank you so much, Gordon, for all your time.
Thank you very much.
A little something for you to take home. Okay, Gordon is probably not running off, so he's here for another few more minutes. If you've got any other questions, can people come over to you? The answer is yes, you can. Okay, thank you all very much indeed, and look forward to seeing you at your opera tomorrow and the new talk next month.